Thank you. So as the previous speaker, I would like to thank Arthur. Some years ago, I was invited by Victor in Warsaw with the so-called at that time EBMT Chronic Leukemia Working Party. And I had a great time, and this time it's, I cannot say even better or more better, but in 24 hours...
Much better. Yeah.
Much better, that's your point. In 24 hours, I was able to see two World Heritage sites, absolutely outstanding, one yesterday night and fantastic tour this morning. So Arthur, thank you very much. And thanks also to be able to share science with your colleagues from Poland and also from all over the world. I really appreciate it. In contrast to David Wesel, I will not talk about fancy and very new and expensive drugs that for most of us we don't have access to, except in the US. I will talk about very basic treatment, such as autologous stem cell transplantation, and I will also mention allogeneic stem cell transplantation, even though this is quite controversial nowadays in myeloma arsenal treatment. So the most important question is combining IMiDs, proteasome inhibitors, and steroids. Do we still need transplant, auto-transplant? And if so, who should get it? When? How can we improve the chemotherapy preceding the transplant? And shall we do a double transplant, as we used to do 20 years ago, actually? Science goes back and forth. And should we use it at relapse? And what is the role of allogeneic transplantation? So these are the questions we'll try to answer. So first, auto-transplant remains a major treatment approach in myeloma. As you can see, these are the last EBMT data, and over 10,000 patients do get autologous stem cell transplantation each year in Europe. And of course, as you can see, this is much more than allogeneic transplantation. And in terms of indication, by far, myeloma is the first indication for autologous stem cell transplantation, first before lymphoma and solid tumors. So these are the facts. So we still do auto-transplantation in myeloma, and it will remain so for a long time, I believe. And why is it so? Because we do have now some trials challenging the best upfront treatment we have, and the most two convincing trials have been performed using the best combination of Velcade, Revlimid, and Dex, plus or minus autologous stem cell transplantation. That was the study by Cavo and the French IFM study that I will show you again. So that was published a year ago. So you've already seen the schema, but I remind you that all patients got RVD up front as an induction regimen, and then stem cell collection, transplant up front or not, delayed at first relapse, VRD for those who did not get 5 times VRD, for those who did not get the transplant, and lenalidomide. And the big difference between that, so that's, as you know, a joint study with IFM plus the FCI, and in the US they gave lenalidomide until progression, while in France it was only for 1 year. And as you know, the results are very convincing in favor of autologous stem cell transplantation up front. As you can see, I'm sure you're very familiar with these results in terms of VGPR, partial response, but that was already shown. Now the new endpoint is MRD, and MRD is, as the first speaker mentioned, obtained in 2/3 of the patients, while it's only 1/3 without the transplant. So it's really in favor of the autologous stem cell transplantation. PFS is higher, statistically significant, but it's fair to say that the overall survival is the same in the two arms. It's also interesting to mention that even though we proved superiority with autologous stem cell transplantation, this is not really the case for the most high-risk patients, such as cytogenetic high risk, as you can see here, stage 3 myeloma patients, and IgA isotype. So for these patients, especially, as you know, high-risk cytogenetics defined as either translocation 414 or deletion 17p, that may not be so convincing. Who should we transplant? So we should transplant up front. Who? Well, you are aware, I believe, that we moved from the artificial 65 years old limit to something like 70, and in the US, I heard that there is no limit, as in many things in the US. But for sure, what is more important than the chronologic age is the performance status, the comorbidities, and many scores have been described. At the last EA meeting, we had 3 presentations in favor of autologous stem cell transplantation for patients above the age of 65. I will mention 2 of them. The first one was presented by Faith Davis, and that was a retrospective actually analysis from the myeloma 11 trial. The main question in the myeloma 11 trial was the role of maintenance, Revlimid versus placebo, and actually they showed again that Revlimid was important to administer as a maintenance treatment, but this is not the topic here. They looked actually at the age of the patients, and this is interesting because some patients were getting autologous stem cell transplantation, and others were not, and the decision was based actually by the physician and the patient. So it was very much close to the daily life. It was not a randomized study, okay? But they showed that between the age of something like 60 and 75, you had patients who were transplanted, this is the blue ones, and for practical reasons or others that were not transplanted. So they looked at this patient population. And here, so they did a post-hoc analysis, transplant versus non-transplant, age matched, okay? And that's important. The decision to transplant was on an individual basis, based on performance status, clinical judgment, and participant preference. The numbers are quite high. You see in the transplant pathway, almost 1,000 were transplanted less than 65, 300 between 65 and 69, and a smaller number, 50 above the age of 70. And as you can see, the PFS is actually the one expected with an auto transplant. It's almost 2 years higher for those who got the transplant, if it was planned or not done. And that's found also in terms of overall survival. So that's another argument showing that it is fair to do auto-transplant above the age of 65 with the new limit of 70, and the transplant-related mortality was very acceptable. In the same EA meeting, we had a retrospective study showing again that if you transplant above the age of 65 or below the age of 65, actually you had the same PFS and the same OS. So at least in France, and you may remember that the past trials were not in favor of transplantation for patients less than 65. Well, now the new consensus is to perform autologous stem cell transplantation upfront until the age of 70 years. What about the chemo? Well, as you know, melphalan, high-dose melphalan, 200 milligram per meter square, and less, 140 if you have a renal insufficiency. Well, it has not changed, actually. Many trials have been done combining, for example, melphalan with busulfan. The Spanish have done that with no superiority. We've done, as you know, Velcade plus melphalan, and I will show you, actually, we did not improve anything. So today, it's simple. It remains the old melphalan with the same dose. So these are some trials that have been combining additional drugs, but the results were not in favor of the combination. And Muriel Roussel was kind enough to send me her slides that she presented at the last ASH meeting. So that was a phase 3 trial. Actually, 2 phase 2 trials were in favor of combining melphalan with Velcade, but the phase 3 failed to show any benefit. So that was how it was designed. You had Velcade before high-dose melphalan on day -6 and -3, and on day +1 and +4. And basically, that's the PFS. The PFS is the same, and the OS is strictly the same. So there is no advantage in combining melphalan with Velcade. However, Kassilbash, our colleague from Houston, MD Anderson, did also a study, as I mentioned, with busulfan, and for high-risk patients, and that's a phase 3 randomized trial, he was able to show statistical superiority combining melphalan with busulfan. So that's a single study, but maybe for high-risk myeloma patients, you may have to combine melphalan with busulfan. So, transplant up front for all eligible patients. Melphalan remains the standard drug. What about double transplant? That was already mentioned earlier. It's not very popular in the US, but it's coming back, at least in Europe, and especially for the high risk. And in my institution, actually, we have switched back, if I may say, to tandem transplant, tandem auto for 17p deleted patients. And I will show you the phase 3 trial supporting this comeback with the double transplant. Just going back 15 years ago, you remember that the IFM compared, well, that was, of course, when we did not have the new drugs, but there was this study comparing single versus tandem, you remember? And tandem was superior to a single transplant, and both PFS and OS, but that was especially true, we mentioned that earlier, for patients who did not get VGPR after the first transplant. But the fact is that nowadays, most of the time, we do reach VGPR, at least VGPR, after a single transplant, and we stopped actually doing tandem transplant for the last 10 years. And that was also because besides the IFM, who were able to show PFS and OS survival, the other teams, the Italians and the Netherlands, were not able to show any overall survival benefit. For all these reasons, we stopped doing double transplant. However, the EMN 02 trial described here, after a VCD induction, a non-transplant arm with VMP and a single or a tandem transplant, plus a consolidation or no consolidation, and a maintenance, lenalidomide maintenance until progression. That was presented this year, last ASH, and again this year, and they showed superiority of double transplant in terms of PFS and OS, and especially, and that's the most important slide, especially for high-risk patients. When you compare patients with high risk who got a double and standard risk, it's absolutely superimposable. So that's a strong argument in favor of double auto-transplant for high-risk myeloma patients defined as 17p or translocation 414. And that's why, why in Europe there's a switch to a double transplant, at least, again, for 17p deleted patients. However, that was mentioned, and that's why the US colleagues are not yet back to the right path. The stamina trial that we already discussed didn't show any benefit to add a consolidation, either with VRD or double transplant. And as it was explained, maybe that's because they had a different induction regimen, and also because they all got lenalidomide maintenance. But you saw that also in the EMN trial, they also got lenalidomide maintenance for all patients. However, there was no difference in the three arms, and therefore tandem autotransplant is not done in the US. So to summarize, double transplant versus single transplant, both the CAVO study this one was in favor, and while the US, the stamina study, was not supporting double transplant. What about auto-transplant at relapse, at least at first relapse? The consensus treatment is to perform auto-transplant if the first remission, as was mentioned by Professor Vezol, was long enough, at least 18 months, and now that they get Revlimid maintenance, at least 36 months. But it's fair to say that, as he mentioned, if you give Revlimid Dex plus Dara, you will get a long PFS at first relapse. So that's what we knew with retrospective studies, and I have to show you again, this is the only randomized trial comparing an auto-transplant versus no transplant at first relapse, and that was the Gordon Cook study, myeloma 10, I think. that was the design. So relapsing at least 18 months after prior auto, and they got PAD, high-dose melphalan auto transplant versus cyclophosphamide, but it's fair to say that the control arm was absolutely not optimal, and nobody would do that nowadays, but that's the only trial, really randomized trial in that setting. And the response rate were superior with the auto transplant, and as you know, there was a benefit in terms of TTP, PFS, and OS, but again, the PFS with the auto transplant is only 19 months, which is actually what we get with Revlimid Dex without DARA. If there's no question that auto transplant should be done up front at relapse, it's more questionable. And again, also in this study, high-risk cytogenetics remains a so-called unmet medical need because there was no benefit of the auto transplant in this setting. So that's for the auto transplant. What about allogeneic stem cell transplantation? Well, I was a little bit reluctant when I had to review this part, but you always have people who claim that they were able to cure myeloma, as it was also mentioned earlier, with an allogenic stem cell transplantation. And it's also fair to say that I've been treating myeloma patients for more than 18 years, and personally, I have never seen any of my patients cured. They all relapse, even 15 years after the diagnosis. I was very surprised. We mentioned all these new drugs. We are improving dramatically the remission duration, but strictly speaking, cure, I'm not sure. Maybe operational cure or functional cure, as you mentioned, will be the next step, but we're not there yet. But it is also fair to say that allogenic transplantation has a high morbidity and mortality also. And even with RIC, the mortality has decreased, but it's still around 15%. So, however, I'm going to show you the data. So what about the auto RIC allo approach that was done by many groups? And Josta Garten was kind enough to send me his slides. And outside of Benedetto Bruno, who published 10 years ago in the New England Journal a benefit of the allo-RIC versus auto in terms of PFS, and Josta Garten with his famous NMAM 2000 trial, and that was true both in terms of PFS and OS. The other groups, and especially the Americans, the CTN network, didn't show any benefit of the auto-allo transplant arm versus the double auto, even for high-risk myeloma patients. So, but if you look at the very last published slides from the EBMT study with this approach, a higher TRM with the RIC allo around 15% at 60 months, 5 years follow-up. A much higher relapse in the auto arm, and in the end, it crosses, the PFS crosses around 2-3 years, and it gets bigger and bigger, and the allo arm is apparently superior to the auto arm. Probably at relapse in the allo setting, the response with the new drugs is superior compared to the auto setting. And in the end, that's the most important. The overall survival, Josta Garton is claiming, is superior in this approach with the allo-RIC post-auto tandem. However, no people are doing auto-allo anymore upfront. What about in first relapse in what's so-called chemosensitive patients? That's what is actually recommended by the most important consensus. Well, again, this is a study from the CIBMTR and a retrospective study showing that in this setting, you do have higher relapse with auto compared to allo, higher TRM again with the allo, and in the end, auto was superior to allo, both for PFS and OS. So I'm not sure this is the right thing to do. Again, a different study addressing the same patient population. And in this retrospective study, that's the contrary. They were able to show a PFS and an OS advantage for patients who get a donor versus those who did not get a donor. Finally, for allo transplant, what about high risk and upfront for high risk? Well, this is very much called investigational, and that should only be done in a prospective trial. I'm just mentioning this Seattle study with this regimen showing that, so they compared patients who got auto-allo for high risk, either at first relapse or later, and they showed that if it should be done, it should be done early in the time of the disease course, and you still have this around 15% of TRM. New allo stem cell transplant approach, I'm not mentioning the cord blood, but that has been done in a few centers. But this is, I believe, not done anymore. However, the APLO, for those of you who do allo transplant, APLO is a big thing. This is a small study reported last year. It's an Italian study showing some interesting results with the APLO approach, but this is a very small, 30 patients. And actually, I can tell you that we are combining the data from the EBMT and the CIBMTR, and we have about 100 patients, and it will be very soon submitted. And the results are more or less what you see here. So maybe the APLO approach may be interesting in myeloma. New cellular therapy, I will be very brief because David presented nicely the CAR T cells that has been mentioned with the different targets, and as he mentioned, the results are encouraging, but it's not as good as it is for diffuse large B-cell lymphoma, where you see a plateau, while in myeloma, the median PFS is around 10 months, you mentioned, or maybe 11. And one of the reasons may be that actually in myeloma, the T cells, the CAR T cells, disappear quickly compared to the lymphoma scenario. So in conclusion, how do we treat myeloma patients in France? Well, like everybody, and everybody gets an auto transplant until the age at least 65 and maybe 70. Consolidation, yes, we do a consolidation, and maintenance, yes, maintenance, lenalidomide maintenance, but for how long? we don't know exactly. The IFM recommendation is more or less 2 years. That's the ESMO recommendations, the European recommendations. Again, all transplant-eligible patients should get an auto upfront with no consolidation and lenalidomide maintenance. And I'm showing you the Mayo Clinic recommendations, the last ones. It's a little bit different because for standard risk patients, they may delay the transplant. This is absolutely not what we do within the IFM. But besides this subgroup of patients, they all get high-dose melphalan upfront. And to conclude, so I remind you that these guidelines, they define now high risk as transplantation 14-16, 14-20, and deletion 17p, and the 4-14 is in the intermediate risk. So, Shaji Kumar presented 10 years ago the major improvement in the treatment of myeloma, as you can see here, and this is related to both the new drugs and the auto transplant. And this has been updated in 2014, and with the same benefit of the auto transplant, and especially actually in patients older than 65. Thank you very much. I'm willing to answer to your questions. Thank you.